Hi, I'm Dr. Gene Wright, the CEO of the COPD Foundation, and I'm excited to talk to you today about an idea that might break some preconceived ideas, some myths, some stigmas that you've held in the past. We once thought that chronic lung disease was a disease of older men, white men, smokers. In fact, if I asked you to just think for a second, close your eyes and think of somebody that personifies COPD for you. That person's face might look a lot like this gentleman on this screen. A little weathered, a little wrinkly, cigarette, thin, not always, but this might be the persona that comes to mind. My goal in the next few minutes is to take that myth and bust it and replace it instead with this picture. Precious baby, future bright, looking forward to it, but perhaps a future that's filled with chronic lung diseases like COPD. So this talk's entitled Chronic Lung Disease Starts in Childhood, or even COPD starts in childhood. So we're going to go through a series of articles in the literature. We're going to dive deeply into the science. We're going to convince ourselves and hopefully eventually convince others, much like a skilled attorney would go before the jury, presenting the evidence and building that compelling case. I know from me, as I've become aware of this over the last few years, and you're going to see some of this science, with all due respect to the investigators, is not rocket science, nor is it novel science or new science, but it's science that's been around that, frankly, most of us, myself included, have ignored or at least put on the back burner because from early age on, as either medical students, PA students, respiratory therapists, whatever your branch of medicine is, COPD, chronic lung disease, and smoking were woven together to the point that we often refer to COPD as the smoker's disease. Not long ago, Dr. David Menino, our chief medical officer at the COPD Foundation, and I were talking. And as many of you know, Dr. Menino has been in this field for a long, long time and really influenced the development of the scientific literature. Dave has an unusual career in that besides being a clinical physician, he also did what I call a tour of duty at the CDC, the Centers for Disease Control and Prevention in Atlanta. And Dave, in his unique, playful but piercing way, would ask the leadership at the CDC, where is our program on COPD? Where is our focus? Where's our energy? Where's our time? Where's our dollars on COPD? To which he was told, we don't need that. We have a smoking cessation program down the hall. See, even the Centers for Disease Control was so convinced that it was a smoking disease that once you put in smoking cessation or public awareness about the risk of smoking, you could dust off your hands, kind of straighten your collar, and feel like your job was done. But Dr. Menino knew better, and now many of us around the world know better. And we're now raising that story that it's not just a smoker's disease. One of my team members often says that she would like to write a paper or give a talk in defense of the smoker. And I think there's two sides to that. One is not only does smoking accelerate damage to the lung, it is addictive. And as we've learned through other forms of addiction, that cycle of addiction is not so easy to break. And so while we would never want anyone to start smoking, or in these days, vaping, we know that even if you step into that as a path in your life, stepping out of it, right, is really, really hard. But let's take smoking and everything that comes with it as an adult, and let's put it on the side table. And let's look at childhood and let's see what happens. But first, a little bit of history. So we're going to turn back the clock, not to 1946, which would be far enough back, but to 1846, when Hutchinson first described the use of a spirometer. Ladies and gentlemen, I would submit to you, the jury, that the ability to understand lung function, lung capacity, is over 150 years old. So, as I said in the opening, this is not rocket science, not novel science. It's been around for a while. And what I like about Hutchinson's article and his Da Vinci-like engineering drawings in the tech is that he uses a phrase in the intro, the value and the predictability of forecasting disease. He doesn't say and lung disease. Now, that may have been a bit of slip in the writing on his part, but we're going to make the argument that your forced vital capacity, your FEV1, your forced expiratory volume in 1 second, have a predictive aspect to them that was discovered over 150 years ago. Our job is to bring something that was so clear and compelling in 1846 to the future so that it can become part of our knowledge and integrated in how we see care. I know at this point you might be rolling your eyes and going, I know Gene's older, but I didn't think we'd go back quite that far. So we won't stay in the 1846. But when you look at a metric, a machine, a device, a marker that has been reliable, repeatable, sustainable over time, there's nothing better than spirometry. And so fast forward, that's why we still urge spirometric readings to be done even today in 2025. So let me draw your attention to an article from 2019, and you're going to hear the name Alvar Augusti and colleagues a lot in this talk. And Alvar and his team published in the European Journal of Internal Medicine in 2019 this paper, and to me, most importantly, this drawing. This drawing in the center shows that there is a time in life where we are building capacity, we are building function, and then over time, we're going to hit the peak or the plateau, and then as gravity, age, cycles around the sun pull on us, that curve will begin to decline. Slowly in some, maybe 30 cc's a year in loss of lung volume. Faster for others, perhaps 60 cc's a year for some. And if you were never able to reach the same peak or plateau, your curve might look considerably different. In fact, as in every group, there's always the super achievers. So there's some, I personally think they're probably NBA players or unusually tall people that stand out not only in the basketball court and the crowd. And so their peak, their plateau, and their decline looks considerably different than those of us that have a lower center of gravity. So Dr. Augusti goes on to say in his paper, although we acknowledge that research gaps still exist, we still don't know everything in this field, we propose that spirometry be accessed, be performed during childhood, adolescence, early and late adulthood. And it can be done so in a way that's reproducible, non-invasive, safe, and affordable, making it a global health marker to identify individuals in the general population at risk, respiratory and non-respiratory, non-communicable diseases. So in this context, spirometry may act as the caged canary. Interesting analogy to embed in the body of a really scientific paper, and we'll see why. But spirometry may be the caged canary that miners used to carry into coal mines to alert them of dangerous accumulation of gases, thus providing an early warning mechanism and thereby saving lives. There is so much packed into this paragraph. This is a repeatable test. It's reliable. It's global. It works all over the world. You don't have to adjust. We thought for a time that you might need to adjust for races, and that race-based spirometry has now been placed aside. But it can be a marker of warning. Here's what the future looks like. So when I read Alvar's comment, that little phrase, and I love a good word picture and a good metaphor, caused me to do a little digging. And so, in fact, here are the coal miners headed off into a mine, and here, as part of their armamentarium, is a little yellow canary in a little cage, right? Because this little bird is their early warning detector of carbon monoxide. And so carbon monoxide, which is odorless, clear, is a killer. And the workers wanted to know, had they accidentally unleashed a toxic gas that they would not know was in the air until it was too late to get out of the mine. And the little bird, having a faster metabolic rate, would show symptoms of that so much sooner. So if the coal miners, and anybody for that matter, that far under the ground, knew the importance of an early marker, an early screening device, why have we in the lung health field taken so long to get around to using a marker that might show warning, call it a lighthouse, there's rocks ahead, call it a depth plumbing device, call it the canary in the coal mine, call it what you will, but we have needed and we have had just such a device, but we haven't deployed it in that manner. So let me simplify Alvar's elegant drawing. And some of you know I'm from Detroit. We're a very plain group of Midwesterners, and we speak very plainly. So here's my Detroit version of his elegant slide. We start here at the intersection of X and Y, and we put age and years across the bottom, and up the scale, we put either FVC, the total vital capacity of the lung. In fact, just this summer, I had the opportunity to meet with Alvar, and he said, I love that phrase that is vital. It's the meaning, it's the thing that gives you life. What a great phrase. And it was stuck on there over 100 years ago. It could have had a really geeky name, like we name genes and cytokines these days. But instead, vital capacity is your vital capacity. All right, I'm going into preaching right now. Or you could use another metric like FEV1, maybe even peak flow. But whatever metric you use, all of us will have a curve where as we grow during years 0 to 20, we are building that capacity. And at some point, probably in adolescence, maybe some peak early, maybe some in their 20s, maybe some 25, but somewhere in this age group, our lungs reach their maximum capacity. And then over time, we decline. So I've got a curve. You've got a curve. All God's children got a curve. And we have our own curve. Well, we talk about personalized metrics. What if I knew what my curve looked like? Oh, I shouldn't have said that. I'm jumping ahead. So let's go back. Let's build on this. So let's look at this article. Forced expiratory volume in 1 second is not just a lung function, but it's a marker of premature death from all causes. Wow. This is from Young and Hopkins out of Australia, 2008. And they say reduced FEV1 identifies not only undiagnosed COPD, which many of us have a passion of finding the missing millions, uncovering those that are still yet to be diagnosed, but has a comparative utility to that of serum cholesterol. Wow, there's another great word picture, another powerful analogy. So it's comparable to cholesterol in assessing cardiovascular risk, and it defines, in his study, those smokers of greatest risk of lung cancer. As such, reduced FEV1 should be considered a marker that identifies smokers at the greatest need of medical attention. So, you know what that means? It means besides using FEV1 as a marker of how well your lung is doing, it becomes a life marker of your lifespan, of what you're at risk for. So I go to my doctor's office and they weigh me, they measure me, they take my blood pressure. Nobody measures my forced expiratory volume or my forced vital capacity because, see, they've already biased me. Now, maybe it's to the good, but they go, "You're not a smoker." Click, right? And they move on instead of saying, "Oh, even though you're not, that number, like cholesterol, like hemoglobin A1C, like all those other important markers, will tell us something about your life going forward." Young goes on to say, accordingly, the lungs function as the body's most important sampler and filter of the environment, and FEV1 becomes a barometer of the body's response to systemic inflammation from chronic air pollution exposure, and in particular, smoking. So I was at a conference recently, Clean Air, North Carolina, and I learned in North Carolina, there are 300 devices around our state that are measuring air quality. Now, these are outdoor air quality devices. And if you live at this intersection, you might know what the air quality is there. If you live in Raleigh, you might know what it is there. Well, you know what? Jean Wright is her own measure of air pollution, of the environment, of all those things that are going in my lungs and going on around me. So when I say I have my own curve, I do, right? And this climbing the curve, we'll talk a little bit about that in a second, and sliding down the curve, all become personalized to me and what I'm exposed to. So I am my own sampler and filter. And if I knew my FEV1, which I do now, okay, but if I knew my FEV1, I would be thinking about my own health and lifespan differently. So this article from Bowman, Marat, and Lang out of Copenhagen from the Copenhagen City Heart Study in 2012 showed that it is a combination of the level that you reach, the peak, and the decline. And now what I want you to begin to see is it's not just one investigator in one part of the world, although there's a similar group of names that you're going to see popping up in this literature because they are now beginning to feed off of each other and to build a coalition, particularly in Europe, of people who really understand this idea and are making it practical. So this one is a combined effect of lung function, level, and the decline in FEV1. In New England Journal of Medicine in 2015, 3 longitudinal studies were reviewed: Framingham, Copenhagen, and Lovelace. And they looked at patients under the age of 40. And again, the maximum FEV1 that you reach, this is going to be important now, the top of the slide, and the rate of decline, right? You know, was the the payload in the study. And in fact, the authors say the main new finding of this study is that lung function value reached in early adulthood seems to be important with respect to the diagnosis of COPD later in life. Our data suggests that approximately half the persons who later reported with airflow obstruction had a problem going up the slide, and another half had an accelerated trip down the slide. So it's both and. Doing a journal of medicine doesn't get any better than that, or maybe it does, but that's really a tip-top journal that's calling out for younger people. Again, we often don't diagnose people with COPD until after 40. We don't even begin to measure them because screening or routine measurement of lung function has never been a part, at least of American medicine. I think it's becoming a more regular part of European medicine, but there are some practices now where when you go, in fact, I go to an internist, my college-age daughter goes to an internist. The first time we subscribed with this new physician, we had spirometry the first time. And the first serious conversation we had was, what's our maximum FEV1, right? And what does our curve look like? Or what do we think our curve will look like? So again, I'm from Detroit. This is how I pull these together. The fun you're going to have on the big purple slide here depends on the height of the slide, right? And the slope of the slide. It's honestly that simple. When I think about ways of communicating with patients, if I were pulling out my handy dandy notebook or showing them an easy to understand educational tool, I'd probably use something like this because everybody gets it. So let's move on. Does it matter whether it's your peak FEV1 or your FVC? This group of investigators out of Spain, and their group comes up frequently in this, they said in a long-term population-based cohort, we found that low levels of FEV1 and to a lesser extent FVC achieved at the age of 21 to 35 predicts risk of, you thought it was going to say COPD. It says predicts a risk of early cardiopulmonary mortality. I would submit to you, the jury, that I would do FEV1 if I didn't do it for the lung at all. I would do it for a marker of early prediction of cardiopulmonary risk. I know my cholesterol. I know my triglycerides. I even know my LP little a lipoprotein, whatever that thing is, or at least it's on my chart. But if I don't know my FEV1, I'm missing a really useful, repeatable marker of life overall. In an elegant study, investigators look to see, is it your background, like the advantages or disadvantages? And later we're going to cover how the social determinants of health factor into this. But if you have the unlucky draw of the social determinants of health not working in your favor, and you were a smoker, your rate of decline is faster than others, which makes sense, right? It makes sense. So I like to say longevity correlates with longevity. I wish I had made up the word longevity. And my hat's off to the folks in the lung cancer field who use that phrase quite a bit. So I'm going to shamelessly steal from them. And in this paper, again, Augusti from Spain, 2017, he shows in those dotted lines, those Kaplan-Meier curves, that the green line represents mortality, right, the length of your life, in people who had a normal FEV1 at age 25. So I have a couple of college students living at my house. They're my children. And they're both the same age. And one has a normal FEV1 at age 20. And so from that alone, I would say she's highly likely to follow the green curve. The second child has a lower FEV1. We might refer to him later, and I sort of know why. But he has a lower FEV1 in his college age, which again, separate from the likelihood of getting COPD or any other chronic lung disease, is going to make a difference in his longevity. Or if unmitigated, if not understood, if not put into his awareness, like probably not a good idea to be standing in a place toasting marshmallows over a fire pit in the backyard. For other people, it might not trigger anything. For him, it might trigger coughing, asthma, but it may accelerate, right, COPD. And especially if that was a repeated exposure, perhaps like working as a first responder or a firefighter, where he's constantly being exposed to that. In this paper, again from the group in Spain, it's titled Chronic Obstructive Pulmonary Disease Pathogenesis. And I thought, wow, I don't think I've heard the phrase pathogenesis since maybe med school. It's just not in my vocabulary. It's not something I think about. But it's really good to go back and think about, how does the disease occur? Many years ago, some of the leadership of the COPD Foundation, we were sitting in an office at the NIH, and we were, in our righteous indignation, asking for more funding to be directed towards National Heart, Lung, Blood Institute, and more of that funding being directed towards COPD. If it's by any scale, either the third leading cause of death worldwide or the fifth leading cause in the U.S., particularly of non-communicable diseases, you would think it would have a higher priority in funding. And yet, despite the high morbidity and mortality, it was like 173 in priority of funding. As we had that discussion, one of the leaders of the NIH said, Gene, I even wish we could explain to you, how does this disease actually occur? What causes this? We understand HIV on a very molecular level. We understand heart disease and the kind of plaques that break off from the plaques that don't break off. We miss some of that fundamental knowledge about chronic lung disease. Wow. I was shocked. I was disappointed. And I realized we have work to be done. And I think papers like this that came out in 2020 are so important because they cause us to go back to that second year pathology class in med school, or your pathology training as a physician associate or as a nurse practitioner or a respiratory therapist. So Augusti and team say COPD can start early in life. See, this isn't a Gene Wright-ism. In fact, when I spoke to him this summer, I said, Alvar, what you have said over the years, what you have embedded in the science, the way you and Bart Celli and so many other investigators are pouring your life into this. What I want to do, frankly, through talks like this, is augment that. Bring it with the Detroit style into a way that it's so easy to understand that people won't forget climbing up the slide and sliding down the slide. They won't forget that they need to have that number on their phone. They won't forget that every college student, besides having a laundry card and a bus card and a dining room card, need to have a card that has their FEV1 on it. No joke. I really think they need to. So he goes on to say, COPD can start early in life. About 4 to 12% of individuals in the general population never achieve normal peak lung function in early adulthood. And therefore, the therefore is mine, but you can hear him say it, and therefore are at risk for developing COPD and other concomitant diseases. Later in life, and there's that mortality thing, and dying prematurely, 4 to 12%. So let's pick a number somewhere in the middle of that, 8, 9% maybe. Take 100 college students, 100 high school students, and count the first 8, right? They already have a future that has been cast for them, that if they knew it, if it was on their cell phone, if it was in their medical record, just like an allergy is known and recorded, maybe the thinking about how you live life, how you spend life, whether you get vaccinated to protect yourself against respiratory illnesses or other illnesses that might trigger your immune system overall, it all comes into a different focus because now you know. So 4 to 12% in that young age group are at risk. 4 to 12. That's a really high number. So let's go back to the easy diagram. So here's the curve, and now we're going to look at what's in the green box. And I think one of the things that first stands out is everything that determines the height, right here at 20, occurs before 20. As my kids would say, well, duh, Mom, right? But most of my time, the last 15 years in the world of COPD, has been focused over here at 40, 50, and 60, right? Either getting the invisible cases known, the missing millions, either getting the right treatment to the right people at the right time, so helping care management, care delivery, getting virtual or in-place pulmonary rehab to those that are diagnosed, so even though they have the disease, they have a higher quality of life. They avoid admissions and readmissions, or that awkward word that we use medically, exacerbations. Patients don't say that to me. They say flares. I'm not doing very well. I had a setback. I went back to the hospital again, right? They have a high 30-day readmission rate. We were focusing here on the slope instead of turning our attention to what happens in the green box. So the second half of the talk is what does happen in the green box, and how much of that is impactable? Is it so entrenched that it is what it is? Or are there some factors that through public policy, advocacy, civil engineering, clean, intentional city design, monitoring, we might alter that rise to the peak and perhaps even help it? I know I sound like, a rose-colored glasses kind of person, the cup is half full kind of person. And indeed, I am. Because Lord knows I would not have stayed in the field of COPD for as long as I would not have stayed in the field of COPD as long as I have, were there not hope. And there is hope. There's hope not only in the second part of the slide with all the new therapies and interventions, but I'm going to put before you, the jury, that there is hope in the green box as well. Let's see how convincing I can be. So in this study by Jordan and McAvoy, they look at the trajectories of lung function in infants and children, and they set a course for lifelong lung health. 2020 study, so fairly recent. Gene is no longer quoting literature from the 1840s. So this is a mere 5 years ago. And what I like about this study is it's in pediatrics, right? And I think those of us in COPD have often been internal medicine specialists, adult pulmonologists, people in the world of geriatrics, people that focus on aging. And I say, pediatricians, come to the table. It's time to have a talk. And I think what has happened is we've had two groups, the pediatricians and the adult-focused providers, and we've stayed in separate camps. I know that because I started my career as a pediatrician. And I never thought about COPD. I never thought about what might happen to that preemie that I was caring for, except I did think they're at higher risk of RSV. I think their bronchopulmonary dysplasia, either caused by their damaged lung from their prematurity alone, or from the mechanical ventilation that we provided, or from the lack of surfactant, or a myriad of things that happens in the world of neonatology, I knew that would impact them. My analogy back then, and I often use sports and football way too much, is in American football, right? We've got the yardage, we've got 100 yards. And in fact, my hands go farther than the screen. So let me bring it in. We have 100 yards. But when you have BPD, when you were a premature baby, you lose lung volume. Even if we weren't measuring all that, there's just not as many of the alveoli, and the bronchi are damaged in their structure. And so, again, it only makes sense that the ability to get to the peak of the slide is going to be altered. But as a pediatrician, when somebody turns 18 or 21, we usually say goodbye, right? And then I practiced in Atlanta for a long, long time. And the children's hospital was on one side of the street, and the adult-focused hospitals were on the other side of the street. And we used to kid, hey, it's time for you to cross the street. And we meant it literally. And the care went from our side of the street to their side of the street. It was most startling in the world of CF, as gratefully kids were getting better and better care, and they were living into their 20s, into their 30s, into the 40s. And then when they crossed the street, there was now a group of providers who had to learn a new skill, and that was the management of cystic fibrosis. But I digress for a second, and it won't be the only time. So let's look at the graph that Jordan puts up here. And instead of just focusing on the peak of the slide, he and his team help us understand the blue line is a child with a full-term birth who gets to that peak as other people get to the peak and can expectantly have perhaps a normal decline, a normal ride on the slide. Compare that to the premature infant who is not going to reach that peak. So remember when I told you about my two kids? Well, they're not twins because they're adopted. They do function a lot as twins, and they actually function a lot as my own personal randomized controlled trial at home, because I have one with a normal FEV1 and one with a limited one. And why is that? Because he was premature, and he was in an area of low socioeconomic status where the social determinants of health were a big factor. He was in a rural environment, a dusty environment. He had childhood asthma. He had repeated infections. And so now at college, while their SAT scores might look the same, while their college t-shirts might look the same, while maybe their interests in snowboarding might look the same, their FEV1s, their FVCs look radically, radically different. And so you can imagine when mom gets the call of I'm coughing or I seem to have a flare in my asthma, I know, right, who I really need to focus on. And that's what Jordan and McCoy did for this. They showed us in 2020 how this path of prematurity begins to set that course. They even help us with a very elegant diagram that literally goes week by week through the life of the fetus to show us here's where genetics come to play, right? If you're dealt the hand of alpha-1 antitrypsin deficiency, boom, right? That's at conception. If there's some epigenetics that are influencing your mother during that time. In fact, as I dig deeply into this field, I love the stories that are in these articles. The story like the canary in the coal mine, right? The story that says a young man who smokes in high school and quits and later becomes a father. His child, his child is at higher risk for having a lower FEV1 at the peak and a higher incidence of COPD. Wow, that's powerful. And who would have figured that one out, right? We can sort of draw the line between mother and baby. We could draw the line, I guess, between mother and father and baby because of genetics. But father alone, wow, that's something that makes us step back and go, it's not just genetics, it's epigenetics. It's what's happening during the pregnancy to eventually lead to either a full-term baby that's going to achieve its full lung potential or a child that's going to be thwarted right from birth. No choice on that child's part as to whether they're going to sign up to be in that 8 or 9% that are at risk for chronic lung disease. And I think this is where probably I do raise a little righteous indignation when I hear people say, I have COPD and I never smoked, or I had COPD and I smoked. Right? Let's just take that smoking part aside, because what happened from 0 to 20 was not under your control. It wasn't your choice. It wasn't your variable to influence. It came from genetics, epigenetics, the environment, poverty, being disadvantaged, malnutrition, all the way to obesity. All those things were being put in motion and impacting whether you would be at risk for lung disease. Carry that forward. Peter Lang out of Denmark and colleagues in 2021 put out this very nice review about what happens in childhood and adolescence. So I talked to you about the preemie and the pre-delivery phase, whether you're a 38-weeker or 40-weeker, right? The closer you are to a 40-weeker, it's always better. The closer you are to a full-term normal birth range, the better, right? Those are things that really help put you on that right trajectory. And so Dr. Lang and his colleagues make a really nice table of all the things that might impact our low FEV1 child or patient. And as you look at the list, there's prematurity, but there's maternal smoking, even grandma smoking. Now, I can think about that, and I hope grandma is a phase of life I will enjoy at some point. I'm not a smoker, so at least when I'm holding that grandchild, they won't be getting secondhand smoke. But now I'm also realizing grandma's genes were different. Mama's genes were different. Daddy's genes were different. They're all piling up. And then what happens during childhood? Did you have asthma? For the longest time, I practiced in Atlanta, and I saw kids come from all parts of Atlanta. And Atlanta is blessed with some great sections of wealth, but it's also entangled with some, I like the phrase, corridors of opportunity. And in those corridors, true in Atlanta, now true for me in Charlotte, same thing. Access to care, having either a pediatrician, a family physician, a PA, a community health worker, somebody that's watching you and measuring you over that childhood becomes a rarity. I think I'll never forget a boy who came into the children's hospital and died from an asthma attack right in front of us. And it was his birthday. And he didn't want to stop at his birthday to tell his parents, I'm having my asthma attack and I can't breathe. Now, truth be told, I'm not sure that even if he told them that the rescue inhalers, which were his only form of therapy at home, would have made a difference. But as we say in the South, that boy upped and died from a disease that should have been manageable. Maybe not preventable, but at least managed in a way that could have allowed him to move on to adulthood, right? So all those factors, premature, full term, childhood, adolescence, and now we're being faced with a generation that some think vaping is safer. That's a campaign in and of itself, but it's scary how much something that entered our culture as a substitute for smoking or to help wean people off of smoking now is creating a generation of new problems. Lang goes on in an elegant diagram to show the types of chronic lung disease that form. That's your column on the left. Your endotypes. So what happens to you with all those triggers, with either smoke, irritation, inflammation, as how do those puzzle pieces fit together? And eventually, how do you present as a patient with your phenotype? I recently attended the European Respiratory Society meeting, and I was pleased the number of times I heard speakers say, it's not one COPD, like it's not one kind of cancer. It's a variety. It's a mixture, an admixture of different phenotypes based on what your trigger was, what your predisposition was, how it formed in your body, and then how it presented. And I think in the next decade, we will see a maturing of this language where we understand the premature infant who becomes a COPD patient versus the asthmatic or the repeat pulmonary infection child who becomes a chronic lung disease patient looks different, and truth be told, we'll probably be treating them differently. Mark Dransfield in 2022 and a team of brilliant scholars pulled together the Lancet Commission entitled Towards the Elimination of Chronic Obstructive Pulmonary Disease. That was the mic drop. That was the shot heard around the world. That was the turning point. That was the moment where people said, we don't have to just sit back and be Eeyore and whine about there's no new drugs, there's no new this, there's no new that. We don't get enough attention. We don't get enough NIH funding. It's now time to call it out and say, we can eliminate, we can reduce, we can prevent this disease in millions of people. And in this elegant study, yet one more great diagram from prenatal through adulthood, the factors, the environment, the social determinants of health, and how they all come together. We knew the starting treatment, starting diagnosis at age 50 was too little too late. But 20, 30 years ago, we didn't know quite what else to do. Today we do, right? The puzzle pieces are coming together. That thinking about the child from 0 to 20, the measuring and repeated measuring of FEV1 and FVC, the understanding of the environment. There is an intersection in LA that if you raise your windows, and you probably do because it's hot and air conditioning is expensive, the LA buses park at that intersection and their fumes come up to your apartment. Your risk because of that intersection, because of that apartment, because you raised your window goes up. We can get that precise moving forward. We can tell people living in this zip code. Like I love the phrase that says, your zip code is as important as your genetic code, right? Where you live, it tells us so many things, both directly and indirectly. Just this year, 2025, Diaz et al. Wrote in the New England Journal an article entitled The Prevalence and Prognostic Significance of COPD in Adults Younger than 50 years of age. So if you have this disease and you're younger, is it important? Absolutely, right? It's not, oh, it's asymptomatic or we haven't diagnosed it in you yet. It's there and it's brewing. And in fact, I like his phrase, and look how close his statistics are to the other articles. Young COPD was present in 4.5% of adults under 50 years of age in the cohorts examined. The diagnosis was associated with premature mortality as well as respiratory and heart failure events. So the fact that you have a chronic lung disease brewing in you as a young person, it gets back to that story of longevity and longevity. It's going to impact you over time. This article was so important, it earned an editorial called Seize the Day, the importance of early detection of COPD. Now, let me step back for a second. I spend some portion of my time in my job lobbying in Washington and trying to get elected officials, some of whom will go back to states where they're in a district that has people that raise watermelon and that don't really understand COPD. Not because they're not smart enough to, it's not on their radar. They're not talking medicine. Some will go back to a zip code in North Carolina that has Duke and UNC and NC State and Elon, and they're going to get it and they're going to figure it out. We need our congressmen and women, our senators from states like mine to get it, to understand that waiting until somebody has symptoms is too late to start the FEV1 FVC measurement. Now, I'm not naive. I am hopeful, but I'm not naive. It's not going to happen overnight, but it's going to happen when we pool our voices, our energy, this literature together in a way that becomes powerful, that becomes compelling. Hoping I'm winning you over as a jury. I hope I'm convincing you to think differently after this talk. I'm hoping that you'll go back to your practice and say, instead of making FEV1 and FVC something we do at the annual Medicare wellness exam, which, oh, by the way, isn't even included in that, let's move it up because we owe it to our patients to see the risk of mortality overall and their risk for lung disease. I'm going to begin to draw this to a closure and cite Andrew Bush. Andrew is at Imperial College in London, is a pediatrician. Yay, right? Been thinking about this stuff for a long time. And in fact, we had a chance to have a cup of coffee together at ERS and talk about this. And in this article, Social Determinants of Respiratory Health from Birth, is it still a concern in the 21st century? Absolutely. In fact, he has an elegant diagram copied here of all the social determinants of health and how they factor in. Now, I must confess, like I've become a bit of a groupie. When I like somebody's writing, I track them down. So this summer I wrote Alvar Augustine. I said, I've been following you. I've been reading your stuff. My family's going to be in Spain for a different reason, but can I come up to Barcelona and meet you and talk to you? Well, I felt the same way about Andrew Bush. I wanted to sit down and talk with him. And so finally at ERS this year, we were able, along with Dr. David Menino, to sit down and talk about this and hear it from the horse's mouth. And he went on to tell story after story after story of things that happen in childhood, why we need to get into the schools, right? We have jump rope for heart, right? What do we have in our schools for the lungs? How do we educate our schools? How do we, get that message across? So Andrew goes farther, and his words are so powerful. I just copy them and put them in here the way he writes them. The social determinants of respiratory disease are important across the developmental spectrum and across the world. Be it known that countries are not uniform and there are islands of deprivation, even in high income settings. And in fact, in the article I just quoted, he goes through the different continents and shows the difference. He further says history taking should include the determination of poverty status with focused and sensitive questioning. You remember zip code? Where did you live? Where did you grow up? I often say in America, we love our rural America. Sometimes we don't show enough love for rural Americans. He goes on to say pediatricians must advocate for the fetus and the child to stimulate political action to address poverty, indoor and outdoor pollution, and nicotine exposure in tobacco and vapes. Access to basic and expensive medications and healthcare facilities are aspects of deprivation, powerful word, aspects of deprivation which must be addressed. The greatest burden of exposure falls on those who are already suffering deprivation. Well, let that one sink in, right? Those corridors of opportunity, right? That sets the pregnant mom, the young dad, the smoking dad, it all factors together. He says we could achieve a step change in lung health without recourse to expensive medicines with a strong political will. With understanding these roots of the adult disease in childhood, right? And understanding it from conception, antenatally, childhood, and on. He says there's 5 key factors to lung development, shown here in this little diagram, right? Maternal, child, as 5, just 5, enough that we should be able to remember or have on a tick-off sheet. And what I like is he goes on to say, this is his exact quote, the onset of chronic obstructive pulmonary disease can arise from either, remember we talked about this at the beginning, failure to attain the normal spirometric plateau or from an accelerated decline in lung function. Despite reports from numerous big cohorts, no single adult factor, bold, underline, no single adult factor, including smoking, accounts for this accelerated decline. By contrast, 5 childhood risk factors, maternal and paternal asthma, maternal smoking, childhood asthma, and respiratory infections, are strongly associated with an accelerated rate of lung function and COPD. We reviewed this article about a year ago within the COPD Foundation, and we all went, how did we miss this? How did we miss this clarion call? And back to my simple diagram, Andrew is telling us, like this purple curve, if you have some of these childhood factors, your rate of decline, and perhaps this yellow dotted line either shows when your FEV1 drops below 70% or when you begin to present with symptoms, either one, you're going to get to it faster than the person who does not have those childhood factors and their only trigger was smoking. Now, hear me. I am not giving a license to the world to smoke. We don't want that. But we know that these 5 childhood factors are what accelerate the decline. One last paper to look at. Again, Alvaro Agusti and the team, Rosa Ferrer, they say there's a new form of omics. We have genomics, proteomics, metabolomics, all the omics you can think of. They're using a phrase, getomics, G-E-T omics. And they say human health and disease are the final outcome of dynamic, interacting, and cumulative gene, environment, and time. That's the G, the E, and the T. It's your gene, what you came with, your environment, that's your mama, your daddy, your grandmama, your neighborhood, your rural, your smoke exposure, your indoor cooking, your biomass fuels. And then you take that and spread it over time. You know, if you cook a marshmallow and make a s'more as a one-time thing at camp, right, you're probably okay. But I often say, if you were a first responder and you ran into the towers at 9/11 and you were lucky enough, fortunate enough, blessed enough to run out, you probably ran out with COPD. I just saw a chart yesterday that said 440,000 people were living in that blast environment and are at risk, right, for lung cancer, for breathing that polluted, damaged air that was not just there on 9/11, but hung in the atmosphere for days and weeks. Auguste goes on to make a really elegant, I call it embroidery, that we start in life with a few factors that are really important. And even if you can't see, the words of the diagrams, what's in the center is having an FEV1 lower than the lower limit of normal, the LLN. And over time, we get bombarded with more and more external variables to maybe like the phrase, oh, what a tangled web we weave. Not quite the same context, but it all adds up. It all counts. Remember, as a kid, you used to ask the teacher, is this going to be on the test? Yeah, frequently the answer was yes. It's all going to be on the test. It's all going to lead to longevity, chronic lung disease, earlier presentation of the disease. So let's put this all together. Going back to 1847, we have a reliable measure of lung capacity and function. We know that a combination of the peak and the slope both matter. We know that the peak is determined by factors from conception to adolescence. We know that there is at least 5 key risk factors that impact your lung health as an adult. And we know that the social determinants of health impact lung health development. I'm going to close with a little guy that we have affectionately nicknamed as Little Walsh. John Walsh was our founder. If John Walsh could speak to you as a child from his childhood and tell you about his journey on COPD, this is what it would look like. Thank you.